Hello, good afternoon, everyone. Welcome to our third webinar in our Together in Care series. This one is entitled Palliative Care in the NICU and Beyond. How does ethics fit in? We have our speaker, Dr. Brian Carter, here today, and I will share a little bit more about him briefly. But just wanted to cover a few housekeeping items before we get started. So we have our QR codes available. We have CME credit available for physicians, APPs, as well as nurses. That can be accessed here. We also have MOC Part 2 questions available. And we just wanted to advertise our next webinar with Dr. Stephen Leutner. That will be on May 13th next month. And he will be focused on creating and carrying out a palliative care birth plan. So that's very exciting. And at this point, will have Dr. Carter start sharing his slides, and I will share a little bit about him.
Can you see my slide, Shannon?
Not quite yet. Here, I'll stop share. I think it is your slides showing now. So we are very excited to welcome Dr. Brian Carter. He is a professor of pediatrics and the chairman of the Department of Medical Humanities and Bioethics at the University of Missouri, Kansas City School of Medicine, as well as the interim director of the Children's Mercy Bioethics Center. And we are delighted to have him today. So without further ado, I will hand it over to Dr. Carter to get started.
Thank you, Shannon. Thank you, Aaron, and others for the invitation. Nice to know people are interested in the question, and I'm sure you will throw some questions at me before this is all done. So this will be a very rapid, brief, and not totally comprehensive review of ethical considerations in neonatal palliative care. And neonatal palliative care is a niche of pediatric palliative care, and it's a piece of perinatal palliative care. So just trying to get our bearings as we look to the next slide. Hello. So I will try to talk about a little bit of history and the ethical journey. There are a number of recurrent themes which questions may be addressed around, and there are some specific needs, and I'll give a nod towards where we need to go in the future. So because this is an ethics talk, I thought I would start with a philosophic observation. And when I read this a number of years ago, I really thought that this was an insight that resonated with me, and how fortunate we are to bear witness and participate in, even celebrate two of life's greatest moments, namely birth and, unfortunately, death, and how much that gives us pause. We're trained in critical care with pertinent attention to the neonate. We need to know fetal physiology to understand the child that we're presented with at birth. And we have to acknowledge that sometimes critically ill children do, in fact, die. And we can anticipate that, which is good, but it's always considered out of sorts, not natural for children to die before their parents. So it gives us a great pause. And I put together this timeline simply because I wanted to organize my own thoughts about this. Um, I give great credit to Jonathan Whitfield and colleagues in Denver who really first addressed hospice concepts in the NICU in the early 80s. I did my residency and fellowship in Denver, and I had the opportunity to meet him and work with others that worked with him. Jonathan was dually trained in both pediatric ICU and neonatal ICU. And in describing the care of severely handicapped or dying children, he looked back on early works that came from the 70s, not the least of which were from Yale and Campbell, Duff and Campbell, Ray Duff and Alexander Campbell published really a seminal paper describing what was going on in the care of severely handicapped and non-viable children at Yale in the 70s. And it was really somewhat controversial. But nonetheless, as neonatology started to continue its forward progress, ability to care for increasingly complex children, not the least of which was a little bit more effective ventilation in the 80s than in the 70s. But that, as you know, improved even more so with microcircuitry and moved from conventional to high frequency and synchronized ventilation in the decade of the 90s. But that was one influence, if you will, in the early 80s. A second was reflected on by Tom Murray in the Hastings Center report. And that was the reality in 1983 moving forward of HIV/AIDS and perinatal acquisition thereof. I participated in the care of a number of children with perinatally acquired HIV/AIDS, as well as pediatric HIV/AIDS associated with blood component therapy before it was being tested in 1985 forward. And really the development of AZT, the trials for the use of AZT to prevent perinatal transmission really weren't published until 1994. And things improved there, as you know. But the same timetable as we moved through the decade of the 90s brought information from Brian Calhoun and Nathan Holtke and Hinson. Basically, what was presented not only in Neonatal Network, but also the American Journal of Obstetrics and Gynecology, the concept of perinatal hospice. In other words, if you identify what appears to be a life-limiting or life-threatening condition in utero, can care be reoriented towards hospice care and followed with comfort care after birth? One of the sad realities of our specialty and our colleagues in obstetrics is that with a diagnosis prenatally, be it made by sonography or rarely CT scan, nowadays a little bit more refined with maternal fetal MRI, the whole pregnancy becomes medicalized. And what at one point was the wonderment of pregnancy and the ideal outcomes that parents dreamed of is now just been torn apart. And what we do, and when I say we, I mean collectively, what we do is we oftentimes will be yearning for more information. And so there'll be more testing, more imaging. There's now, as you know, genomic testing accessible through pubs or amniocentesis. And this all does not fix or aid or contribute to the benefit of the fetus. It's all for the physicians as they try to inform the needs that will require attention when the fetus becomes a newborn. And so information is good, but it's not really directly impacting the fetus. So if in fact one wants to change gears and pursue perinatal hospice, one would not pursue successive imaging and testing. There'd be appropriate monitoring of the pregnancy, but not necessarily an expensive and elaborate, detailed laboratory and imaging investigation, as it were. As you all know, in 2000, the AAP put out its first statement on hospice and palliative medicine, and it was really published by the Committee on Bioethics from the AAP. There was no section on HPM. And about the same time, I was doing work with Anita Catlin, a family nurse practitioner and investigator in nursing science from the Napa Valley. Her husband, they're now retired, is a vintner. So I did some work with her and others in trying to look at, well, if we're given this situation, how can we respond? And secondly, if we're caring for a child who's critically ill in the NICU and we're moving towards an obvious decline towards death and dying, how can we make that as good as it can be? That is filled with comfort and respect and dignity and opportunity for bonding. And again, no further medicalization or escalation of care. And you have to realize that in the decades of the 70s, 80s, and 90s, it was almost inevitable that if a child was dying in the NICU, that yes, there might be ultimately a withdrawal of life-supporting medical technology, but it was also accompanied very, very often by codes, chest compressions, medications, and if a patient's already on ECMO and dying, all of that is absolutely futile, and it becomes quite literally a bloody mess and cruel in my estimation. So these were motivations that really moved me to understand how we might improve things. So at the time, I was at Vanderbilt, and like many great institutions, things don't really matter until you've produced the data. And especially if you want it to change locally, you have to use a study that produces local data. So I did, and in 2004 published a paper on circumstances surrounding death in hospitalized children. And most of the children, as you know, die in the PICU and the NICU. These were deaths that occurred after 24 hours in hospital, and 10% occurred on the oncology wards. But this was a snapshot that was being taken by myself and others around the country that published similarly, that gave us insights to how hospice and palliative medicine might make things better. Well, why was I concerned with that to begin with? Pretty much because I tuned into bioethics in training during the baby doe years, and took some courses at Georgetown and decided that I would make that part of my scholarly endeavors in practice. I've been an academician both in the Army and out of the Army at a couple of medical schools. And so this became an opportunity for me to develop a thread of scholarly work and investigation. Hence some publications that basically came out as the notion of pediatric palliative care caught on in the early 2000s, and between 2008 and 2020, there was an expanding literature base. And as you know, in 2013, for the first time, the section on hospice and palliative medicine in the AAP published continued guidance, if you will, pediatric palliative care and hospice care commitments, guidelines, and recommendations. And that was published in 2013, and it's probably time to publish another one, or certainly update it. The Academy tends to update guidance every 10 years. So where do we find ourselves today? We're looking at ethics, and ethics in the context of the NICU, and both in the context of palliative care. Basically, in the last couple of years post-pandemic, as you know, there's been enhanced attention to moral distress, and that is an increasing need for ethics consultation that we'll talk a little bit about. And also of note, publications in journals you might not expect have started to arrive, including Journal of Pediatric Surgery. So surgeons are attending to this, critical care docs are attending to it, family-centered care clinicians across disciplines are attending to it, and that's where we find ourselves today. It's been an interesting journey. So we'll go ahead and get to the next slide here and talk a little bit more about palliative care in this 40 years. These were contributions that have been made. Some of you may have known Dr. William Silverman, who practiced at Columbia Babies Hospital in New York City. Met his wife while they were in school. She, ironically, was a hospice nurse. And so Bill actually wrote an editorial that came out about the same time as Jonathan Whitfield's paper, talking about the notion of hospice considerations in neonatology. That was not his forte. His forte was evidence-based practice. And yet I had met and had lunch with him before and had discussions about these issues. And until he passed, he would send me encouraging email threads, and always ended with the phrase, if any of you knew his handle in AOL, it was Fumer, F-U-M-E-R, at AOL.com. And he was an eloquent thinker, and I was happy to know him. And he would always end his email messages with "strength to your arms." You know, it's a might keep the fight going, etc. So now we have moved into the decade of the 2000s, and what happened in 2000, the Joint Commission said we needed to pay more attention to pain. And if you look at descriptions of pain medicine in the NICU, the year 2000 is a point at which there's a great inflection and uptick of publications accordingly. The reality then that I've often lived with, and you do as well, is that birth, life, and death are all social and existential and relational events, and time matters, context matters, people matter, cultures matter, spirituality, philosophy, etc. And it really, in my mind, is a privilege for us to be able to be present at these times and continue to consider the human element and not get bogged down in technicalities. Some of you may have seen a posting on the AAP palliative care listserv that I put up in response to a question in the last couple of days. And I encourage to avoid the medicalization of dying. And I would still advocate that that be the direction we go. So the first consideration with regard to ethics is no surprise. It's communication. And those of us that have been doing ethics committees for, ethics committee work or ethics consultation over any number of years would tell you, as well as I'm sure you've experienced if you were on the requesting end, communication issues contribute to 85%, if not greater, of all ethics consult queries. What's the right thing to do? Well, what have we talked about? Who's talked to whom? Is the decision maker in the room? Is the authority figure approachable? And so I think here communication has to be reciprocal. It has to be reliable. As the Irish playwright George Bernard Shaw once said, biggest problem with communication is the fact that we presume that it actually took place. And it may not have. It may have only been one piece of it, and that's information sharing, but it might not have been well received or understood. I think also it's important, and this has entered a couple of my papers over the years, that we understand liminality. And liminality is being in a place between. So the pregnant mother is experiencing liminality in that she was not pregnant before, she is pregnant now, and she's going to deliver. And so the whole of pregnancy might be considered a liminal space and time. Liminal spaces and time occupy our minds as well as our physical space, and basically demand that we understand uncertainty, that we accept uncertainty because we're not sure where we're going and the condition we'll be in when we get there. If you and I were to talk about liminality, maybe 5 years ago, I had a certain element of health, and now I have a different element of health. And at some point in between, I needed to seek attention. We see this in every NICU admission. The NICU is a liminal space. People enter the NICU not being in utero anymore and not dependent on maternal physiology. And they now are dependent on us and technology, and how they will graduate from the NICU and the health condition that they will be in is unknown. So we don't know if the baby will live or die or be disabled or dependent on life support technology or other apparatus technology at home. And we don't know exactly the course that will be tread by the newborn in the NICU on admission. We don't know if the child will develop BPD or NEC or have other infections or other crises, intracranial bleeding included. So what this means is we need to accept the fact that we are walking in this liminal space and talking and basically bearing witness and accompanying every parent set of every child in the NICU. That's not something you learn about in medical school. It's something you learn about in practice. But it has an ethical dimension in that it addresses accompaniment. It addresses the meaning of what it is to be a good physician, how to provide patient-centered and family-centered care, and how we can find some sense of comfort amidst uncertainty, which then is further complicated by values plurality, whether it's culturally or spiritually driven, or whether it's just the way I think is different from the way you think, and I won't get bogged down in the modern context of that. I'm sure of palliative care literature that basically talks about different death trajectories. So we can look at these major categories that have been well described. You might look at the tiniest, earliest, most seriously ill, peri-viable, if you will, or extremely preterm newborn, and think that we know it's going to be a rough road and it's going to take some time. It could be weeks, it could be months, it might even be a year or more. But we anticipate that we'll achieve a certain health status that will be sustainable. Depending on what chronic illness the child is discharged with, however, you can see the second from on the top right corner, the gradual debility of a child that might have complications of prematurity can be stretched out over years. That first box that is sudden and unexpected death might in fact reflect sudden unanticipated infant death, what we used to call SIDS. Or it might reflect a genetic condition in which the baby's lifespan is going to be short, or there can be other complications. Some children are born with a very poor quality of health, and they live only brief hours to days. And then others never really have a great quality of health. They have an acceptable quality of health, but their life is basically one of decline. And with progressive decline, things that come to mind here, spinal muscular atrophy and Duchenne muscular dystrophy. Though there are changes that may be amenable to gene therapy as we now look at them. So it's not only about death and dying, as you know, palliative care is about living a life of quality and both attaining and trying to maintain the best health-related quality of life or health status that we can. It's also important to understand from an ethics perspective that we attend to the narrative stories of pregnancy, birth, and life in the NICU. This is a picture of Juniper French, used with permission of her parents, who I've met and worked with, even presented on a panel with them. And Juniper is now probably 12 years old and doing quite well. But what's the backstory about this pregnancy? If you've ever read this book, Juniper, that's the title, Juniper, the girl who was born too soon, and I have no conflict of interest in promoting the book. The backstory of the pregnancy is a very interesting one. It was not a, if you will, natural pregnancy. It required assisted reproductive technology. There's a story behind that, and there's a story that continues with it throughout the pregnancy. And so what does the pregnancy mean? What's been learned while the baby is in the NICU? How do parents cope? And what do they wish for, wonder about, and worry about the most? So these things really need to be ascertained because they're part of the child's story, which will inform decision-making, driven typically by parents. Sometimes an aunt or a grandparent has a haunting voice in the past, or excuse me, a little remote from the NICU, but certainly informing choices made by the mother. And we need to know these narratives. Now, in reflection, a number of years ago, tried to put together my observations over 30 years. And this graphic is one that I built over time. If you're familiar with the term satisficing, it is finding a path forward that's satisfactory and will suffice given the constraints on the system. This is described in my mind as, you know, we start in the top left corner. We all have dreams about, you know, life, and in particular with regard to pregnancy, people aspire and dream of pregnancy and parenthood. And then, as John Lennon used to say, life is what happens while you're making other plans. And realities and events then dictate a need for a response: infertility, high-risk pregnancy, premature birth, etc. And we need to then understand that coping is different for different people. For you and I, it typically would be information gathering, the coping mechanism known as intellectualization. If I know more, I'll understand more, I'll be able to cope better. But not everybody copes that way. In fact, some parents are in shock and awe and don't know how to take the news and learn about what it means that their child's born prematurely. They quite literally cannot make decisions. They seem frozen in time and terribly impacted. And then we find ourselves trying to help them understand the condition and learn how to live with the news. Now, depending on coping mechanisms, framing, am I a blue sky person or a chicken little sky is falling? Am I a hopeful person? I might have hope, but do I live in hopefulness? All of these things will help us move to the point of understanding that we're living in a different reality now in the NICU, and we have to disengage with the primary goal, which was having a happy baby bouncing girl at term, and now contend with Juniper in the NICU. So we have to adjust to the new normal. That's the accommodation. And we have to negotiate a path forward, which means we jettison the primary goal and we re-goal. We reset based on the certain conditions and understand that this will help us derive a satisficing answer instead of one that might be optimal. Now, you and I have been through this cycle hundreds of times or more. We know where things go. You put the extreme premature baby in here, you put the baby with congenital heart disease in here, you put the baby with myelomeningocele in here, and we know what's required. We know all the stages, and we are very familiar with this pathway, but parents are walking it for the first time and go through it grindingly slowly. Now, the reason I bring this up is because that impacts decision-making. It impacts ethics. You have to, in my mind, sort of figure out where people are in this little schematic, and that might help you move forward. There are challenging conundrums, if you will. We can be faced with trying to decide who the decision maker is. Is there, in fact, a valid surrogate? Parents certainly have the primary prerogative, but there are times, unfortunately, when parents present themselves as not being valid surrogates, and there are times when social services are required. Those things dictate the environment in which ethical decisions are made. Can I treat individual cases differently, or must I always treat clinically similar cases the same? This is dictated by, again, context and time and culture and values. And then what about withholding and withdrawing life-sustaining interventions? How do we address that? Is it okay to address that? And as you should know, roughly 2/3 of children in NICU and PICU that die do so with removal of apparatus technology that's life-sustaining. So with regard to the valid surrogate, we basically are trying to see that the parent or guardian is working towards the infant's best interest. They're present, they understand, not just that they're present, but they understand what's going on. They're listen and learn, and they can respond to your questions as well as ask reasonable questions themselves. They're engaged in the care of the baby. They take the situation seriously. They take time for self-care. We may help them in all of this. And they are balancing other life necessities. As one approaches discharge from the NICU, there has to be some other evidence for preparation and adequacy of taking over at home, use of parent care unit or rooming in rooms, et cetera, sometimes assist in this. And then when support is needed, will parents avail themselves of that? So for the last 5 years, I've limited my practice to NICU follow-up clinic, and it's an issue that is poorly attended in America, unfortunately. Less than 20% of neonatologists do any NICU follow-up. If you go north of the border to Canada, it's close to 100%. or south of the border to Mexico, again, it's about 100%. So it's a peculiar reality, and I've been to Europe and Asia, and similarly, 100% of neonatologists do NICU follow-up. But in this country, it's the rare neonatologist that's engaged in NICU follow-up, and I can't really explain that other than maybe we're too addicted to adrenaline rushes with all of the things that go down in the NICU. Again, from the standpoint of each case being unique, we could look at the best interests of the baby and the family, but you know, the baby and the family are always unique. And in the paper Doing the Best for One's Child by Jeff Bluestein, he talks about satisficing versus optimizing parentalism. And Micah Hester and Erica Salter recently published about pediatric decision-making. Erica has published a lot on what best interests mean, but she and Micah put together the paper that addresses reasonableness as a relational principle. In other words, is it the superlative best, the aspirational best, the best we can do given constraints of the system, or what's reasonable is best enough, good enough? And I think that it's important to realize as we try to address things like suffering, to treat the baby in the family, you have to treat the family in the baby. So each family is different and hold different best interests. And the thing with us as clinicians is that we may agree the majority of times with those best interests, but we not necessarily agree in the path to getting there. And so sometimes that causes distress. So I've also examined the question of how does nature take its course? Or are we actually sort of fooling ourselves when we use that term? I don't use it, haven't used it for years. But let's start on the left side of this graphic. And there's a baseline health-related quality of life. That can be both in the NICU or outside of the NICU. And when acute illness happens, there is an acute decline. But when we admit a patient to the ICU and support them, we automatically interrupt nature taking its course, because the natural history of the illness without treatment might lead to a demise, or it might lead to, with good care, improvement and assuming a new baseline health-related quality of life. That's now on the right side, the green line. Or it could be that ICU care is continued, or the child is discharged on technology and medications. But if we withdraw treatment in the NICU, there could be a rapid or a slow decline, but nature's not really taking its course. And the reason is that we interrupted nature's course, and now we bear some moral, ethical responsibility for the course of the child. Now, that makes some people squirm and feel uncomfortable, but I believe it's the truth. And we have to admit that part of the burden of removing life-supportive medical technology is that discomfort of realizing we've attached ourselves to the patient and family by the care we've provided. In response to a paper entitled Postpone Withholding as a model in which some Norwegian authors suggested we would resuscitate every baby, and then once we get to 1 week of life, we would decide, it's time to stop, or with the parent's permission and acceptance of some attendant risk, continue to care for the child in the NICU. So this graphic, again, represents in utero health-related quality of life on the left. The child is born, needs to be resuscitated, so we're interrupting natural course of demise that might occur with extreme prematurity, congenital heart disease, et cetera. And we admit the child to the NICU. Now they have a new baseline. They're on life-supported medical technology. The proposal that was in the main article in that issue of American Journal of Bioethics was that at 1 week, treatment would be withdrawn for certain categories of patients, and that would be normative. That's what we do, and we only would continue treatment if the parents suggested that they wanted to. And as you know, then the child continues to stay in hospital, improves towards discharge, might have some ups and downs, but ultimately go home, or could die weeks or months later in the NICU. But again, what's happened even during that first week is there's a sense of moral attachment. And hence the title of my response to that paper, Postpone Withholding Does Not Postpone Attachment, where human beings become attached to the baby and the parents during that even 1 week stay. Other challenging conundrums might have to do with how you feel yourself about your professional practice, your expectations being met. Do you yourself have value in conflict when you deal with certain cases, people, or circumstances? And how comfortable you are in communicating these things. Do you have a safe culture where people can support each other in this manner? Or do we become more than just morally frustrated, but move towards moral distress, which has a little bit more psychological impact, as you know? And I would acknowledge that moral injury might occur, certainly did occur during the pandemic, but moral injury is really a phenomena of abandonment, where those people in charge don't provide what they're supposed to. And you see that, and all sense of being tethered or anchored to a safe place, a rich environment that's culturally sensitive, ethically sound, is falling away from you right under your feet. People express these things differently. These are quotes that I've heard over the years. You've heard them, maybe have said them as well. Yeah, there have been times I've been overwhelmed and maybe even considered that this is working against my integrity. We need to examine these things because they're of ethical import as they impact how we think and present, communicate with, and move towards expectations with parents. Sources of moral distress in the NICU are many. These are no surprise to you. And the original author of the term moral distress that was written in 1983, that is Andrew Jameton, who died recently, had written more recently in 2017 about continued moral distress. And so I excerpted these phenomena from his paper. The question about environmental impacts, this is a pertinent question in my mind. How is your NICU's ethical environment? Can you talk about things, or are people sequestered in little groups and don't talk openly? Do you have a process for resolving problems? Do you do critical incident debriefing after a sudden loss or even an anticipated loss? Sometimes, as you know, there can be a heavy burden of death in the NICU given any week or month, and there needs to be some intervention for staff support. So if you feel like you can't handle things, does that mean I'm morally injured? I think the term has been overused and not appropriately applied in some instances. As I mentioned, it's important to realize that leadership, organizational system type absence or abandonment really is part and parcel of the moral injury equation, first recognized in soldiers. But one of the other things that we find on ethics consultation is that there's not a singular moral code in healthcare, whether we're talking about nursing or physicians or anybody. We aspire to do no harm. We aspire to seek the child's best interest. But even if we agree on what those paths should lead to, that is, no harm, doing good, avoiding harm, mitigating harm, suffering, how we get there is extremely variable. And given a team comprised of multiple disciplines, it's not surprising that people would choose different paths. But what that means is we have to pause and reflect on what the parents consider. Again, not to belabor moral distress, I'll just move past this slide. You will have copies of the slides. We can become so distressed that we realize that solving the ethical problems of healthcare now urgently include global social and environmental advocacy, again from Jameson. So it's more complicated than it used to be. It's not just, I know the right thing to do and I'm constrained from doing it. In fact, we all respond to stressors differently, and we sometimes go tilt towards distress, or sometimes we are impacted positively by an element of stress and some external factors, but also our internal factors. What are our beliefs and values, habits, social support, and coping mechanisms? So stress is present. Do we go tilt and find ourselves distressed? It varies immensely. And so in doing ethics consultation, it's important to be able to talk to individual team members because they will feel differently. Moral agency oftentimes is impacting this, and I just put this graphic together. It's surprising to me sometimes that some people think they're responsible and other people don't. Some people are morally aware and other people are not. And if they're aware, they feel responsible. And they are compelled towards making a judgment and taking action. All of these things are rolled into moral agency. But this graphic helps us understand when distress might occur. And the philosopher Carina Furey, I believe from Australia, had noted that it's not just constraint, but sometimes there's moral conflict, dilemma, or even simply, if we can say that, uncertainty that drives moral distress. I found that ethics allows me to live in the tension of values, plurality, and uncertainty, but that requires a certain element of humility and that I don't know everything and my path isn't necessarily the best path. So all of these potential contributors to moral distress that became very evident in the pandemic continue to be present. And they shouldn't surprise you. Any of these can present an ethical dilemma. So the pandemic gave us these examples, and even past the pandemic, we see that moral judgments continue to be challenged. I'm going to move past moral distress and look at a couple of things. This was regaining family-centered care that might have been lost in the pandemic. We had a good 25 years of increasingly improved patient and family-centered care in this country. And then in March of 2020, it all fell apart. And it took quite a while to recover. This was a paper addressing that. So moral distress continues. Ethics. How does ethics play into dealing with palliative and end-of-life care? Well, mostly we're focused on layer A there in the center, patient and family centered. But there are other people on the team besides the neonatologist or pediatrician. And so interdisciplinary team might present tensions or role-related perceptions of what best care should be, the path to get to best interest. And then we're all working in a hospital or a health system, and there are policies and directives, guidelines, hopefully evidence-based, that are driving us to do quote unquote the right thing. And then all of us work in jurisdictions, certainly cities and counties, but also states, and at the federal and even political levels, we find influences on where the ethical tensions might rest. All of these things then shape the direction of who is going to be involved and how we might need to address things. You may need to develop a policy that doesn't exist. You may need to revise a policy. You might be able to do something different, except in your state, it's not allowed. So these are manners in which you can examine ethics and relationships and where concerns might lie. I always credit the source of this graphic. It was Mark Blyton, a philosopher I worked with at Vanderbilt. He's now retired in LA. His last post is with the Kaiser system. So why are some people bothered by a situation and others not? Who's quick to make judgments? How can we work together? All of these things playing out. You sort of marry that with the previous slide on levels. And we have to be able to live in the reality of complexity and uncertainty. They're prevalent in the NICU. They impact relationships, our professional relationship roles and responsibilities. And the reason that they're sometimes difficult for us is that when making ethical decisions, if there's a dilemma, it means there's two convincing and convicting options that could be taken. An ethical dilemma doesn't exist when the obvious good is here and the obvious bad is there. So you got two paths, and in order to do one, you have to not do the other. So they're mutually convicting. You have to take action, but you can't do both, in which case you have to compromise. And human beings don't like to compromise. Let's just be honest. So it's hopeful that through the last weeks and years, we've learned a little bit about resilience, restoration of self, revitalization, and reasoning. Yes, I like mnemonic devices or alliteration. And I think that this is where we'd like to go. These are some pictures of Juniper at different points in time. Once she visited us in Kansas City, and that's my wife talking to her. Juniper's in a pretty pink outfit there. And obviously, she was playing Dorothy one Halloween. I'll close with this slide because I believe that as intensivists, we are often driven by what we believe is an imperative to use technology. And this book, which is not about healthcare, but about ethics in age of pervasive technology, and look at the date there, 1980, guides me because as I read it, an ethics of non-power is obviously that human beings agree not to do everything they are able to do, which then makes me think, oh, wait a minute, the opposite that is I have to do everything I'm able to do. So we live in that tension, but we don't always have to use technology. And now I'm going to respond to questions. Thank you.
Dr. Carter, thank you. One of the questions that was submitted ahead of time that I think segues so nicely with your last slide is, when is it acceptable to tell a family that doing everything, in quotes, is not an option? And could you sort of elaborate on sort of what that means to you a little bit?
Yeah, thanks, Shannon. The big word in that is everything. So when somebody says do everything, you need to unpack it. What do you mean everything? Everything imaginable, everything possible, everything you've seen on the internet, everything that we've talked about before, everything covered in your healthcare plan, everything consistent with your religion and existential understanding, because that varies. And so that really is a conversation that needs to follow the request to do everything. Unpacking that then will give you insights into how you can reframe and you can partner with the family and say, I know exactly what you're saying, and I want you to believe and understand that I'm on your team and we are, in fact, doing everything. Doing something different that you saw on the internet is wonderful because you saw it and Dr. Google said, do this. But your child is not that child. Your child is in a different place. We need to consider all of these facts, consider all of the options, what's been done, what the responses are. And yes, you might hear about doing something different, but I'm here to tell you it won't work. And we don't take part in hurting children just to make parents happy. That might be hard to say, but I think it needs to be said. You need to be forthright and far more directive in counsel than hospice and palliative docs are in general. So this is a situation where directiveness is important. And I would invite you to read a paper by Wynn Morrison and colleagues in which the title, I believe, is Titrated Directedness. Just Google that, Wynn Morrison from CHOP. She's a PICU doc and a bioethicist. The other thing is there's a couple of articles about doing everything. I wrote one with a med peds resident once, and it got published in, I think it was JAMA Pediatrics. And it was unpacking and then realigning with the family. So you could look that up. What do we hear when we hear Do Everything by Kirsten Hirni, Hirni, and yours truly. And also an older one from 2006 by Dr. Kopelman, who was a neonatologist, and it was published in the 2006 issue of the Journal of Mount Sinai Journal of Medicine. And Dr. Kopelman talks about, why people would say do everything. And there's a little table in there. I could have put it on slides here. I'm sorry I didn't. In which he gives 5 or 6 reasons why people would demand that you do everything. One is that they don't understand that you're already doing that. 2, they really don't understand the diagnosis and prognosis. 3, you can't let this baby die because this baby is holding a union together of man and woman or man and partner, and the union will fall apart if the baby dies. One is that you can't make decisions about life or death. That belongs to God. So if you say it's futile, I'll say I expect a miracle. And we have to realize that language puts us in that place.
Thank you so much. Thank you for the recommendations
Are there,
of literature.
sure. Are there questions in the chat that I haven't addressed? I don't see any Q&A.
I don't think
Do you ask parents who are faced with a life-altering medical decision to consider which decision is the most likely to lead them to less regret in the future? Yes, Craig, I think that's important. If you're engaged in this process, you need to be able to realize that parents are trying to write the story that they can live with after the child's gone. So you have to give them the prerogative to do that. We should not take that prerogative away from them and assume that we're the ones to write the story. So I will ask parents what they can live with. And I think that's an important thing it's an act of humility.
All right. Thank you so much. I think we may be running up on our time here. And just a reminder that we have these QR codes here for evaluation, CME, and the MOC Part 2 credits. And then another reminder about our next webinar with Dr. Leutner, who will talk about creating a birth plan in some of these cases. And thank you again, Dr. Carter. That was wonderful.
All right. Thank you. Have a good afternoon.